What an interesting coincidence that we're going to talk about medication adherence following a case in which there's a question of adherence. But medication adherence is actually relevant to almost every case that you will be working with in your practices. So again, I'm focusing on topics that would be high value toward reducing disability from schizophrenia spectrum disorders. And so talking about medication adherence was worthwhile with that theme. So as a background, probably as a reminder for this audience, we're interested in effective interventions during an initial episode of schizophrenia-associated psychosis because a lot happens during those first months to years that can be potentially critical in determining long-term prognosis. The brain is a very plastic organ. It means that it's well able to mold itself to its environment or to change itself to meet or to respond to current conditions. So if we can, early in the course of illness, maximize the family support, help the client to frame his or her reactions to symptoms in a way that's not going to be internally stigmatizing or illness provoking, and if we can frame engagement with mental health services as something that is worthwhile and helpful rather than something that is coercive and aversive, we will stand a very good chance to bend the curve of prognosis far toward the better. So in trying to make all things align, then talking about medications and trying to foster good attitudes around them and good practice around them is quite helpful. The really amazingly good news about pharmacotherapy in first episodes of psychosis is that the response rates are almost astronomical. 70% to 90% are the figures that are cited for the likelihood that anybody with the first episode of schizophrenia like psychosis will respond to whatever antipsychotic drug is chosen. And you'll get a PDF of these slides, and those citations are hyperlinked, so you can click on them and follow them to the original source. So fabulous news that we can get people well, or we can move them farther along toward recovery with almost any medicine that we choose. The bad news is that despite these initial good response rates, discontinuation is very common. Half or more of individuals with the first episode of psychosis who have gotten better with medicine will stop medicine within the first year. And that is unfortunate because when medications are discontinued, and especially if those medications are discontinued abruptly, then there's a risk of recurrence of psychosis. And with psychosis comes risks of harm, hospitalization, and in all ways, a person, it's a setback. So if the goal, as in today's case, was to graduate in a few weeks, and then there's a recurrence of psychosis and a multi-week or multi-month withdrawal from school, then this individual is now behind his peers by 6 months or a year. And if during that 6 months or a year there's another episode that happens, the hole becomes deeper, and both the external consequences as well as the internal narrative, I'm a failure, I'm so far behind, everybody else is ahead of me, just becomes a headwind which doesn't really need to be there. So, and unfortunately as well, with every new episode of psychosis, there's apparently a fresh chance of about 1 in 6 likelihood that person is not going to recover with medicines which were formerly helpful. So helping people to stay on medicines that have been helpful is a good plan. So why would anybody stop taking a medicine, especially one that had been working? So some things are very fundamental, but I don't really have a good answer to explain them mechanistically, other than just people don't want to take medicines. Almost nobody enjoys it because they're, among other things, like a daily reminder that I have something wrong with me. Whether that's a physical thing or a psychiatric thing doesn't matter. People don't like to take medicines. It's also very natural for somebody who's doing well to think, oh, maybe I've recovered. And so really the only way you're going to know that is if you stop taking the medicine. And so again, natural human tendency. And then again, natural human tendency, if I'm thinking that, if I don't see that I'm really being helped a lot by this medicine, but it's making me tired or sluggish or having impaired sexual performance or making me worry about diabetes, what have you, those side effects are real. So people don't want to take medicines that they perceive are more risky to them when they don't perceive that they're being helped. Natural thing. And then there's also things like, especially with the psychotropic medications for mental illness, that ties into all sorts of cultural fears and stigmas. These medicines have historically been overused, overdosed, and misused. So there's a fear around them, because when we overuse or misuse them, we give a lot more people a lot more side effects than necessary. And so, then the culture develops these sort of stigmatizing beliefs, which are widespread, and we as treatment providers live in the same culture as our patients, so we are likely or vulnerable to harbor these kinds of stigmatizing attitudes around medicines. So again, think of clozapine. Oh, that's a very spooky medicine. It has a lot of side effects and it's very dangerous. If these are common attitudes that I hear from prescribing clinicians. So if that is your attitude about clozapine, then imagine how it's going to be when you try to persuade somebody that they should take that medicine, or even if you will bother to have that conversation with somebody. So these psychological factors are, significant contributions to medication non-adherence. And of course, there's the issue of inconvenience. So if I have to take a medicine 2 times a day or 3 times a day, I'm just gonna not do that. I'll forget things, and this leads to more skipping, and that can translate into just abandoning them. So lots of reasons why somebody would not want to take medicines all the time. So what can we do then to help to improve adherence to recommended treatments? Well, first, I'm going to posit that step number 1 in trying to improve medication adherence is to not make medication adherence the central issue. So as a reminder, again, I think most people know this, but sometimes it doesn't hurt to just say it out loud. Mental health care is not about medications. It's actually about caring for people. So again, in today's case, we talked about a primary intervention is focus on everything that is good around this individual's psychology and their life, and help them to see how they can use these internal talents and strengths to have a high quality future. And I would also suggest that when people are doing well, that even when they're not, that we make it less about focus, that we maybe de-emphasize a little bit the talk around illness and symptoms, or at least balance this with an approach of sort of akin to coaching. Let's figure out what you want to achieve in life and how can we help you get there. So if we make the central issue our clients' success as they define it, medications then can be very easily framed as just another tool to help achieve those dreams and goals. So as is a general rule, all times and everywhere, make your treatment about recovery as the first message and as the last message. So I talked initially about some fears and biases. So, do a deep and sweeping view of your own views around medications, and just be mindful of that. So in psychodynamic psychotherapy, we have this concept of countertransference, which is the therapist's unconscious or subconscious feelings that are generated toward or against his or her patient. The psychodynamic psychotherapists make a big deal of countertransference because they'll perceive these things. Even if we're not entirely aware of it, our patients will perceive that we have these attitudes or beliefs around them. So try to figure out what yours are and just be mindful of it so that you won't convey a sense of fear or desperation or control or exasperation or anything that's going to be negative. Because again, if you won't take this medicine for yourself, if you're fearful of taking this medicine on your own, even as a test dose, just imagine what it's going to be like for your clients or your families. Because you're going to tell them to take it every day. So knowing that and checking that was going to be useful. And, acknowledge or, do a very detailed exploration of your clients' goals and fears, attitudes around medication, and fully engage them in discussions around medication treatments. There's a fundamental principle in coordinated specialty care called shared decision-making, which acknowledges that the client is the expert in his or her life and his or her body and his or her mind, and getting them acknowledging their equal standing in the medication discussion partnership is vital, because without them buying in, they will simply check out, and a lot of times do so without letting us know. Also, your family's attitudes become your patient's attitudes. So, including them as equal partners in shared decision-making discussions, or in providing supportive and destigmatized information about the different kinds of treatments and their benefits and risks, with educating, answering questions, and getting family buy-in will go a long way. Because if, for example, if the client's father says, this is just a phase, he'll grow out of it, he won't need these anymore, there's a pretty good chance that the client has that view as well. So getting everybody on the same page in family units will be highly desirable. Again, I know you probably know this, but it doesn't hurt to just say it out loud. Really, really, really go overboard in inviting discussions about side effects. I say this because I hang out in a lot of online discussion areas where people with schizophrenia, spectrum illnesses congregate and talk about their lives and their concerns. And I'm just sadly impressed with the number of times people will say, I'm having a really bad side effect from a medicine, but I'm terrified about telling my doctor about this. At least from my readings, it's because they're going to think I'm a bad patient. They're going to put me on something worse, or I mean, those are the two most common things. But I from reading all these things, I've been impressed by the big gap between me saying, "And are you having any side effects?" and them saying, wishing that they could tell me all the things they want to tell me, but saying, no, it's okay. So I'm going to propose that it is possible, and that it should be the goal. Let me rephrase that. I'm going to propose that it should be the goal, and it's not necessarily an unrealistic goal, that people can be treated with antipsychotic medications and not experience side effects. Or that they can be treated with antipsychotic medications and experience benefits. And I'm getting facial expressions around me like, what? And again, side effects are not they're not an obligatory part of the bargain. It is possible to treat people effectively without giving them side effects. And even if it's not, that should be the goal. To digress, well, and I'm going to run out of time if I digress, but it's so that should be the clinician's assumption, and we should really go out of our way to make sure that we send the message. Again, this medicine is intended to give you an awesome life, and if you have any side effect that makes you not like it, I want to know about that, because eventually you'll stop taking this, and I don't want you to have to do that, unnecessarily. So really, expect that they're there, and then go out of your way to solicit them, and then try to avoid them happening. I think we'll get a lot of, you'll find out a lot more stuff by doing that. And not to forget, long-acting injectable medications can be highly helpful. So if a person's gotten better with an oral medicine, they're finding that it's giving them a significant improvement in life quality with zero or minimal side effects. This would be an ideal situation to convert one to a long-acting version of that medicine. It's also a good argument for trying, if you can, to get to a monotherapy with a single antipsychotic drug, which is actually a usually achievable goal in first episode cases. And if you can have monotherapy with a single long-acting drug that has a once every 2 months or once every 3 month cycle, then for 2 or 3 months out of the year, that client has no daily reminder of illness. And people go to college cannot have to carry pill bottles around. So they're historically, there's an attitude based upon the unfortunate history of the profession that says that the long-acting injectable medicine is for the non-adherent or the bad patients. So there's a little bit of nuance of punishment to this in some quarters. But I would actually think it's more accurate to phrase these as, especially with the newer agents, these represent top-of-the-line technology for pharmaceutical delivery. Imagine that you can get in a single injection something that will release just the right amount of medicine every day for you to meet your needs without causing you a side effect. It's really quite a remarkable strategy. So again, they're useful for the right patients, and just make sure that we are not conveying legacy attitudes of punitive nuance to them. And I think, and it's also helpful, these are the facts. From first episode studies, we know that approximately 20% of patients, if engaged in a systematic dose reduction strategy after 6 months or more of stability. Let me rephrase this. From first episode studies, we found that patients that have achieved remission of symptoms for more than 6 months, who are then invited to engage in gradual dose reduction, about 20% of those individuals will eventually be able to do well with a dose of 0 milligrams of medicine. Another 20% approximately will be able to get away with extremely low doses of medicine, and the rest will at least be on the lowest possible dose. So if we set from the beginning the expectation that our goal is remission of symptoms, and after 6 months or more, we can start to gradually reduce the dose to see if you can be on the lowest possible dose, and maybe 0 if it's possible. You'll, I think, get more buy-in at the front end if the end goal is set as this, and possibly as well if we know that if I have a chance, a 20% chance that I might be able to get away with 0 milligrams of medicine, I may be more motivated to engage in psychotherapies for psychosis, in modifying my environment to try to reduce my stress. My family may be more vocalized to support me. It can get more engagement in these other facets of treatment, and that may have an add-on effect. But regardless, we can make medication adherence in the long term easier by making sure we eventually lower the doses of medication to the lowest possible numbers. And also, the doses of medicine that are required to maintain remission are significantly lower than the doses required to initiate remission. In other words, to address acute psychosis requires sometimes higher doses of medicines than are necessary to maintain remissions of psychosis down the road. That's actually why long-acting injectable medicines are helpful, because overall the blood levels of these drugs are lower in the maintenance phase than they are in the acute phase. So, and finally, as I said, it is a natural tendency to want to stop medicines, and our patients will oftentimes be very hesitant to tell us about their true feelings around, I hate this medicine because of X, Y, and Z. So a lot of our patients will just stop them. I would invite you to try to acknowledge that as a possibility from the beginning and make discontinuation easy. So let folks know that I understand you might want to stop this medicine, and if it is, again, your call, in line with the principle of shared decision making. If you don't want to take the medicine, that is ultimately your choice, and we will support you in our clinic with any number of other services besides pharmacotherapy. But if you decide to stop medicine, please let us know, and we would like to guide you through this process to get you down to 0 milligrams. Because if you've been on a constant medicine dose for 4 weeks, 2 months, 3 months, and you abruptly stop it, that is a recipe for having what's called rebound psychosis, a form of withdrawal. And that rebound psychosis is oftentimes worse than the psychosis you had at the beginning, which then can have a cascade of badness around that. So if a person says, if you say, I'll help you get off the medicine anytime you want, then you can begin to go from, let's move you from 6 milligrams of risperidone today to 5 milligrams next week to 4 milligrams next week. So you can have regular meetings with the doctor around these systematic dose reductions, and you might actually find that when you get to 3 milligrams of risperidone, that now the problems have gone away. So it gives you a second chance to re-engage the patient and find a better dose. But in the end, why say this? a little bit controversial thing is that I don't want to have people do abrupt cessation and wind up in hospitals where then pharmacology becomes reactive and oftentimes unhelpful. So those are my overall thoughts around medication adherence. Let's move on to